Welcome, everyone. I'm Joanna Weinreich, Chief Experience Officer for MedCai. Thank you for joining us this evening for our program, Imaging the Future, AI in Radiology. This is the third program of MedCai's AI in Medicine virtual CME series, and this series was developed under the leadership of MedCai's immediate past president, Dr. Padmini Ranasinghe, and I'm thrilled to turn the floor over to her to introduce our speakers. So thank you, Dr. Ranasinghe.
Well, thank you, Joanna. So first of all, good afternoon, everyone. Welcome to this webinar. I'm delighted to see some of our friends and colleagues joining us here. During my presidency last year, I thought, oh, AI is already here. We have to learn about this. This is a part of that. So we realized we all need to learn. So that's the reason we started this CME series. As you all know, the real task is learning how to use wisely and ethically, so it strengthens our clinical judgment and our connections with the patients. We are extremely honored to welcome two extraordinary leaders from Johns Hopkins, and actually globally, I guess, whose work truly sits in crossroads of medicine, engineering, and innovation. Professor Rama Chellappa and Dr. Hari Sair. Just a correction, Dr. Chellappa's PhD, and he's a Bloomberg Distinguished Professor with joint appointment in too many places, electrical and computer engineering, biomedical engineering, and computer science at Johns Hopkins University. And his bios is extremely long, so I'm going to make it really short so that we have time for Q&A at the end. He's a global leader in computer vision and artificial intelligence. His groundbreaking research has defined much of how AI perceives and understands the world around us. Widely recognized his leadership in developing ethical and trustworthy AI. Professor Chellappa's influence extends across continents, helping shape national and international dialogue on safe and transparent use of AI in engineering and medicine. He had numerous awards and honors, and also is a member of National Academy of Engineering. And next is Dr. Hari Sair. He's a professor of radiology and director of neuroradiology at Johns Hopkins Medicine. And he's a founding director of radiology and artificial intelligence lab called RAIL. His work bridges clinical imaging and machine learning, advancing how we use AI to improve diagnosis, workflow efficiency, and patient outcomes. As a past president of American Society of Functional Radiology, Dr. Sair continues to lead national efforts to define how radiology integrates into new technologies thoughtfully and effectively. I think together they bring a very powerful perspective spanning foundational AI science and real-world clinical transformation. So for the program, we are going to start with Dr. Chellappa, Professor Chellappa, who will discuss data-driven AI in medicine and challenges of data, along with domain shift bias and small data set and interpretability, followed by Dr. Sair, who will explore AI in radiology, highlighting key use cases, evidence of impact on performance and efficiency, and insights into where AI delivers value or introduce new challenges. I think as we hear from them, I think let's reflect how these domains, engineering and medicine, can come together, shape a more trustworthy and effective future for healthcare. So please join me in welcoming Professor Rama Chellappa and Dr. Hari Sair. And so our program, first we'll let them present, and then at the end, we'll have time for Q&A. And you can either type into the chat or you can raise your hand, and then we'll go into Q&A right after their presentation. So over to you, Dr. Chellappa.
Thank you, Dr. Padmini Ranasinghe. Thanks for including me in this program. Can you hear me well?
Yes.
Yeah, okay, good. All right, so next slide, please.
Janine, can you add? Okay.
Thank you. So this is required as part of the presentation, so I'll quickly go over these two things. We're going to discuss the development of data-driven AI. I make a distinction between domain-driven AI and data-driven AI, and so these days we only do data-driven AI. And disclosure is very quickly done. So let's go to the next slide, please. Something AI just came last week. It's not true. It actually was coined in a workshop at Dartmouth in summer 1956, artificial intelligence. Some of the best minds of the country got together for a couple of months and wanted to figure out how this field is going to evolve. And of course, many of you may have seen the Alan Turing's movie. And what I have done here is given a timeline for how AI developed. I call it a bit human-like because a lot was expected of it. It didn't deliver on time, so people soured on it. It came back again, went down again, came back again. So kind of like a human life, we have our ups and downs and so forth. But these are the four areas that became very dominant. Search, looking for the best solution. When you take a Google map, want to go someplace, it searches for the best route. And with natural language processing, it has again become very big now. It always was a great application area. Computer vision, that's one of my areas of research. And that includes all kinds of image and video analysis, robotics, and all that stuff. And of course, expert systems, right? Rule-based expert system. That's how AI started. So I like to say AI pretty much tried everything else before finally settling down on data. I took my first AI course in spring 1978. And whenever AI goes through rough times, we move to computer vision. And when AI gets better, we jump back to it. So we are like that. So I'm a little amused that AI is so much dependent on data now. In the early days, it was all domain driven, but that's okay. It looks like it's working, at least in some applications. Next slide, Jenny. So AI in medicine, again, it's been there for a while. There's a system that was called Medicine, that was built in the early 70s, was not deployed. It was a 500 or so rule-based system to understand a blood infection problem. And it was making decisions. And, it could also ask for further information. It could actually interact with you, not like a chat GPT, but in the old ways. It was explainable and so on. But even then, there was the issue about privacy and computing was not there and so on. So everybody points to Mycin as an example of how AI has impacted medicine long time ago. And there have been many such attempts, but only recently we are seeing real impact. Next slide, please. Okay, what are the challenges and opportunities? There are two big questions we ask when we build AI systems. Will it work everywhere? What do I mean by that? If you build your AI systems using data collected at Johns Hopkins, will it work for the data collected at University of Maryland Hospital, which is just a few miles away? The answer is there's no guarantee. That's what we talk about, domain shift. The kind of data they collect may be different, the sensors they use may be different, etc., etc. And will AI work for all? Is it biased towards a subgroup of people? It doesn't do well. And then, will it make things up? Hallucination. Everybody worries about it when it comes to large language models. And AI will do better if it learns from multimodal data. And medicine is all about multimodal data. There is EHR, there is diagnostic images, conversations between patient and the doctor, and et cetera, right? So it has to exploit that. And the thing is, we do have a lot of data without annotations, and we have small data with annotations. You can't just send a lung cancer picture to an Amazon Turker and say, hey, mark where the cancer cells are, because they don't have any training. You at least need a resident to do that. So annotations are expensive. They are hard to come by. But data is collected every day across all the hospitals. So, right? You have a lot of data, but very little annotation. So special procedures are needed for that, what we call a self-supervised procedure and so on. The other thing is how to leverage data from other labs. Hospitals or medical entities are not comfortable just giving data out. So they can build models, and then you can then average the models. That is the classic federated learning. And, so that's one way to handle that, indirectly exploiting data from everywhere. Of course, the last one is physician-patient AI interaction, developing trust. When I go to my doctor, the doctor has all the certificates from Harvard and Hopkins and et cetera, et cetera. So I say, oh, the doctor should probably know something. But if the doctor says, I'm now consulting this AI box, I want to know where AI went to school. right? So I have to develop trust. I have to believe whatever the doctor is using AI, that it's good for me. Next slide, please. Okay, a few things to keep in mind. There is no single AI, just like there is no single medicine, for all diseases. So we have to kind of, because the data is different, the inference is different, implications are different. So I call it like 1,001 AIs we probably need, okay? And of course, we have a small data with annotations, large data without annotations, and privacy concerns. High expectations, that's the problem with AI. When people ask me, what do I think of AI? I say it's a 2-year-old with exceptional skills in calculus. Why do I say that? The deep learning algorithm that updates the weights basically is calculus 101. But so imagine a 2-year-old that's very, very good in calculus, but it's a 2-year-old, has no idea about anything else. So that's how you have to kind of view AI right now. High expectations. And of course, with medicine, when it comes to medicine, you have to have the right balance between knowledge in medicine and AI and so on to be effective. Domain knowledge is very important. How can you forget that in medicine, right? It's not just data. What the doctor can figure out from the data is very important. So how do you incorporate domain knowledge? And this whole idea of AI is, even Jeffrey Hinton, I think, made a comment 5 years ago that AI is going to replace all radiologists. I don't believe that. AI, what we say is a radiologist who effectively knows AI will have a better workflow than the radiologist who doesn't use AI. That's the way. There's no replacing anything in terms of these skills. Anyway, let's go to the next slide. Okay, I have many collaborations with outstanding doctors in School of Medicine. In fact, that's the one reason why I came from University of Maryland after 29 years to Hopkins in 2020. So we have a 5-year project from National Institute of Aging that looks into AI and technology for AD, ADRD, and healthy aging and so forth. We have now submitted a renewal. And then I worked with the folks in Wilmer Institute in terms of cell phone-based eye images to figure out the cataract and so on in field collected data. I worked with Dr. Robert David Stevens in terms of facial phenotyping for stroke monitoring. And then predictive models are going to be very, very important these are not real AI, but models are important, right? All kinds of regression models are becoming good again. PMAP is a platform we all know. And I have worked with Dr. Prasanna Santhanam in endocrinology on other issues that I show here. We have ongoing collaborations with ICU doctors on how to predict AKI for ICU patients. And in fact, the same prediction method will also be useful to see which patient from ICU can go to the regular ward, making sure that they don't have to come back. There are all these optimization things we can do. And of course, LLMs are here. And we have a paper in NPJ Digital Medicine discussing bias shown by LLMs. So we have other autism work, and then we work with the pathologist, Dr. Alex Barras, developing self-supervised methods for various cancers. The last one, mosquito eradication, it's kind of indirectly related to medicine. Mosquitoes, although they are tiny, they create all kinds of havoc. 67,000 people die every year because of malaria, dengue, and various kinds of things. And I'm not fond of mosquitoes. So we try to find the correct mosquitoes and give the correct treatment so we kind of take care of them. So that is my most favorite project. Please, next slide. Okay, so this is the one slide thing about what I just said, the 5-year project. It's basically a P30. So we try to get various groups in the country apply for proposals, and then we evaluate them and we fund them and things like that. The next slide, please. So this is a summary of this. Over the last 5 years, we have at least picked up 60 pilots. So I don't have time to go over everything they do. Some of us work with the pilots and some they do on their own. Some are from hospitals, some from academic institutions, some from companies and so forth. So lots of stuff is going on. One thing we are now seeing, one thing we learned from here is that it's not only AI is going to help the patient, the doctor, but also caregivers. If somebody has to take care of a person with Alzheimer's, they need help. Okay. The other thing we are noticing, robots are becoming very important, the humanoids and so on, in terms of how they can provide care for elderly at home, watch them and be companions to them and so on. So these are the new developments. robots are becoming important because they can implement the AI systems we do, so we can understand, how it interacts with the world and things like that. And so, yeah, please, next slide. So this is the thing I'm doing with Wilmer Institute. The problem is this: if you collect data in a hospital, eye data, it's very nice. Okay, so we can build a good AI system. But there are all these eye camps that are set up in very remote parts in India, Africa, and other parts of the world, and those are not a great quality image. So when we want to apply AI built using pristine data to field data, the performance is an issue. So that's one thing we have been doing that for almost 15 years. It's called domain adaptation, right? How do you adapt AI built using data A to work equally well on data B when they are having different distributions? That's a very challenging problem. Next slide, please. So before we do that, we have to segment. So there is a nice algorithm from Meta that came called segment anything model, SAM1, SAM2. Now we even go to SAM3. So we can segment the eye, and then we built a transformer-based system. This is, in the early days of deep learning, convolutional neural nets were very popular. Right from 2017 onwards, we have all moved to something known as vision transformers. It's kind of like the autoregression model in time series, and basically focuses on attentional mechanism and so forth. And as you can see, we can segment in the three pictures shown below, and then we go through the three-class problem: healthy, immature, and mature. The thing is, this runs on a cell phone. So on a field, somebody can collect data immediately. They can determine whether a mature cataract is there to be sent to a surgery. As they say, not doing this is a leading cause for blindness. So this is a useful thing that we do with the Wilmer Institute physicians. Next slide, please. This is autism work, in Krieger Institute, KKI. Basically, a child here is playing with bubbles, and we take videos, and there's a caregiver, the parent, and so forth. By analyzing the videos, we are able to determine to some level of accuracy whether the child will develop autism years down the line. So we are actually looking at children younger than 2 years old and so forth. There is some plan to go up to 6 months and so forth. Our collaborators are listed here. So this is a very tough problem because it's very subtle. We can see 30 minutes of video and you may not see much. Suddenly something clicks. And so that's a very tough problem. And that's one of the things we are working on. The next slide, please. Yeah, now I added this most recent work, which we did with Dr. Umair, who was at Hopkins. Now I think he's in Columbia. And the question is that, can we use chest X-rays to learn about this thing known as SLVH? And then what we are doing is when we use deep learning for building something, our vision transformer, we are training this AI system to do something particular. But there's always a nagging doubt. Is it also learning something else? The classic example is diabetic retinopathy. It was supposed to decide on retinopathy, but somehow it carried the information about the gender. That was not the idea. So we wanted to know, when we do this method based on chest X-rays using vision transformers, for example, are there any sensitive attributes also encoded? And that could bring bias. For example, age, gender, etc., etc. So we basically have a method known as mutual information neural estimation. That will tell you in an embedding that we build from the chest X-rays how much age is represented, how much BMI is represented, how much gender is represented, etc. Right? So that is very important. So the clinician will get the full understanding. It's never just a binary thing. There are always the deep learning or vision transformer seem to grab a lot more than what we wanted to learn. Right? So that is what this paper is about. Next slide, please. Yeah, so these are the plots that we have. This was presented at RSNA. So you have the chest X-ray pictures, And what you see there is a heat map that we generate from what is known as a gradient grad CAM. CAM is a class activation map, which tells you which part of the neural network gets excited to give you the decision. Grad CAM is an improvement over that. So this will give somebody like Dr. Sayer an interpretable result. Okay, I see what's going on here, right? So heat maps are important. It gives a visual picture of things that are being decided upon. Next slide, please. So key takeaways, we are able to do end-to-end deep learning models, and as you can see what the AUROC is, etc. Interpretability grad CAM, I push my student to do that. In medicine, it's very important because Dr. Sayer has to explain to the patient why he thinks there is something going on. So interpretability is important. And we also want to know what is dominant, age, sex, and all those kinds of things. Now, the other thing that is making a big impact is from health records, how to make predictive models, right? So you can do classical regression, XGBoost, AdaBoost, and random forest and all of that. We can also do other deep learning methods, but the idea is not to depend on scans and things like that. Lean body mass, you need DXA scans. No, we said, okay, why don't we do it from just age, sex, height, weight, and waist circumference? Okay, so we developed a model on that, and one of the papers listed below talks about it with Dr. Prasanna Santanam. And waist circumference in itself we can learn just from age, sex, height, and weight. So prediction is interesting. Who takes your measurement of your waist? A tailor. Very rarely a doctor will take a tape and measure your waist, right? So waist circumference is one of the parameters for lean body mass, and that itself you can estimate. The third point here is the AKI prediction in ICU, cardiac index and blood pressure, what roles do they play and so forth. We are working with Dr. Faraday Nader and Lee Gödel, and we have recently finished a paper on that. So basically, the idea is ML-based predictions could replace costly scans and useful for large screen, etc. And it should be clinically relevant and useful. There are a lot of papers are being written with AI in medicine. The only ones I want to pay attention is the one that will make a better workflow for Dr. Sayer and other clinicians. If they don't impact the clinical practice, it's not going to be very useful. So you see the other takeaways that have in the thing. So interpretability is very essential and so forth. Next slide, please. Okay, so this is a new development. ChatGPT, they say 1 in 6 patients consults as soon as they get some report, they go to ChatGPT, hey, what do you think? And then ChatGPT says all sorts of things and asks, do you want to know more information? So they can sit there for hours and engage, and they come with all that information to the doctor's office. I want this test. I want that medicine. Because why? Because AI tells me so. But it is impressive, I tell you. I'm amused. I played with ChatGPT a while. So you can give all these kinds of data, CT, MRI, ECG, ultrasound, and it gives its opinions. And you can kind of look at it. It looks reasonable. Of course, there is no verification. There is no authentic, certification from a doctor that, yeah, this is all true. It can do multiple things at the same time and give you some kind of a thing. It says, oh, I can give you this estimate for stroke, this, that. It's a paradigm shift. But you know what? With ChatGPT, it's only going to get better. The more it reads, the more data it does, the more it does. One of my students who just graduated joined Google DeepMind. They're now developing special platforms for cardiology, special platforms for neurology, special platforms for urology, etc. So the question is, can we ignore this? How do we integrate this into the practice for better workflow and things like that is what we have to think about. Next slide, please. Okay, last slide. LLMs. Again, everybody likes. One of my students looked at the LLM and he figured out all kinds of biases it may have. These are all kind of classified and discussed in the literature. There's actually a paper I've listed, 2 papers. They talk about these kinds of various biases and so on. How do you mitigate it? There are prompting techniques. You can kind of educate the LLM. Don't do this. Be careful about this, etc., etc. Or you can also do it as part of training. and so on. So we have an NPJ, digital medicine, where we have done some experiments and so on. I'll encourage you to read that. And I think, next slide, please. I'm actually getting close to my time. Summary. Yeah, I think AI will have significant impact on medicine and healthcare. It will help doctors. It will work with doctors. I don't believe it's going to replace doctors. It may. Well, my nephew is a neurologist. He uses ChatGPT to create reports to insurance companies. Of course, he still has to edit it, right? He can't just directly send it. So those are all fine reports, but it can give you some opinions and so forth, but it's not going to. So the doctors can work with AI, and too many versions will be needed now because there are too many diseases and so forth. But predictive models somehow have similar methodologies and can be useful. And building big foundational model and fine tuning is where we are going. We are doing it for pathology and so forth. Of course, with medicine, there are other issues, FDA approvals, reimbursement, insurance, etc., etc. They are very complicated. But I think, well, Tesla can claim it's an AI-driven car. I'm happy with just the simple protective things it provides. But when it comes to AI with so much data and so on, I think we can look to AI to make our lives better, maintain our health better, and help the doctors to do their work so they can actually have reasonable lifestyle. I have two kids who are doctors, so I know they work very hard. I know all doctors, you guys work very, very hard. So AI will help you to have reasonable working hours so you can spend more time with family. I'm going to stop there. Thank you very much for your time.
Thank you so much, Dr. Chelappa. Let's move on to Dr. Sair presentation, and then we'll have time for Q&A.
Okay, thank you so much. There were so many gems in that lecture. Thank you so much, Dr. Chelappa. Let me just see how I can start this guy over here and then screen share. Okay, I think we got this here, right? And I tend to talk a lot. So I'm going to try to make this quick so we have enough time for discussion later on. I think this is going to be the most valuable thing to do today. So number one, thank you so much for having me to discuss this topic. I was just going to briefly talk about a high-level overview of where radiology is with AI, because as Dr. Chilapa mentioned, radiology seems to have been a focus very, very early on. And, like you mentioned, Jeff Hinton had commented, it was actually 10 years ago at this point, 2016, that radiologists will be replaced. Basically, he said, you don't need to train any more radiologists because you don't need radiologists for in 5 years there would be no need for radiologists. So was essentially what he said. And we are at this point way past 5 years, and our workload has increased since 10 years ago, which is a huge problem. And the way it's going is that, with new imaging technologies and accelerated imaging that we're able to do now, the demand for imaging has increased and is projected to increase in the future. The supply of radiologists is projected to decrease, uh, partly because of one additional factor related to what Jeff Hinton said. There's more recent evidence, right? Because I think people were hoping that with new AI tools being developed, that we could be more efficient and perhaps we don't need to train as many radiologists. But there's some projections saying that AI might reduce the absolute need for radiologists, but it's not going to keep up with the demand. That seems to be what the projection is going right now, meaning that yes, AI will reduce the maybe total number of radiologists that you would have had without AI. Sorry, with AI, or without it, I can't think straight right now. But I think you know what I mean, is that AI would have helped reduce the number of radiologists, but the problem is that the demand is outstripping the help that AI could do, is basically the point. And one of the problems is that, words matter. And when Jeff Hinton says you need to stop training radiologists, what happens is that medical students stop going into radiology because they fear that they're going to have their jobs replaced by radiology. And this has been shown in a paper saying that medical students are much more reluctant to go into imaging science or imaging, medicine because they're afraid that AI is going to replace radiologists. That might change because, as Dr. Chalapa noted, that it hasn't replaced radiologists quite yet, and it doesn't seem like it's going to in the near future. So I think students are going to realize that, yes, the folks that use AI effectively in their practice are going to be ahead, and it's going to be part of our practice in the future. We'll just skip this slide, but just to mention that AI in radiology and neuroradiology. I'm a neuroradiologist, so a lot of this is going to focus on neuroimaging. But there's a lot of AI tools that have been developed, and there's a list online where you can look at how many tools have been approved by the FDA over the years, and there's an exponential increase, right? We can see over here since 2016, exactly when Jeff Hinton started saying that AI is going to be extremely helpful in medicine, specifically imaging. And a lot of these are, as you can expect, radiology tools, because that's what people have been focused on since the beginning. Approximately two-thirds are radiology devices. So in imaging, where can AI help? I know there seems to be a chat. Oh, that's just a QR code. Okay. So in imaging, where can AI help? I think a lot of people are focused on one aspect of it, which is, can AI replace the job that the radiologist does in imaging interpretation, which is just one aspect of it, right? But starting from the total care of the patient in the imaging pipeline, there's a lot of different things that you could do. For example, tools perhaps that could help the patient scheduling, or help the institution with figuring out if a patient might end up being a no-show so that you could use the MRI slot for somebody else. Maybe helping the patient figure out how to prep for the study, which oftentimes, they get confused and then they either don't take the right medication before the examination, or they forget to take the medication, that kind of stuff. And then moving on the imaging acquisition side of things, there may be some tools that can help with, and a lot of stuff that I'm discussing, there are already tools, nascent tools that are being developed or have been developed. But image acquisition, uh, protocoling the study to figure out like what might be the best study that the patient needs. Let's say that you order a regular brain MRI for a patient that has headache. Sometimes what happens is that there might be a finding on there, and then the radiologist recommends a more dedicated study, like a pituitary study, right? But what if the AI algorithm sees that, hey, there's an abnormality that I can see in real time for this patient, so let's actually switch to a pituitary imaging protocol rather than doing an imaging of the brain. Now, the efficiency of the process and having the patient come back has been improved, right? So that I think would be really nice. One other issue that we face a lot is like implant compatibility, patients that have implants, and oftentimes you can't figure out if it's MRI compatible or not. There might be some tools that can help with figuring that part out. For ultrasound, there's some tools that you could use, for example, that would guide you. You put the probe on the patient, and then the imaging assistants, right? AI assistants would help you navigate, saying, okay, you need to go like 30 degrees this way, 30 degrees that way, in order to get best imaging of the liver, for example. And imaging upscaling, so using lower resolution acquisitions, but to reduce the speed of imaging. For example, instead of getting an MR image in 5 minutes, maybe you can get it in 2.5 minutes, but with the same quality. So a lot of things like the artifact reduction, which we'll talk about a little bit. And then another category of workflow enhancement, like when we're reading images, then can we get some kind of tool to help us visualize the images much quicker than we can right now? Like instead of dragging and dropping things onto the screen, can it automatically do that? Can it find automatic prior studies, which might be most relevant for the current study that I'm reading? And then the interpretation side, which I think most people are familiar with, which is like looking at the image and figuring out classification of diseases, segmentation of hemorrhages, right? Volumetric data, perhaps reporting. So you have an image and then it generates some parts of an automatic report. And then part of that too is knowledge augmentation, which is if you see a study, and then I'll tell you after 15 years of being at Hopkins, every single day, there's still multiple cases where I have no idea what's going on. So would there be a way for the algorithm to look at similar cases and help me figure out, what kind of differential I can offer for the patient? And then communication. So once you have critical findings, then sometimes it takes time for us to relay that information right to the referring physician. Could there be automated ways to handle that so that we get notification and then closed loop communication for critical findings, and then prediction based on imaging. Can we predict whether the outcome for the patient might be improved or not? So a lot of different domains I think we can use. And these are some of the things, at least in neuroimaging, that are being used. And beyond neuroimaging, in breast imaging, for example, in chest imaging, for musculoskeletal imaging, there are additional tools that I'm not going to go into because it would be too comprehensive, but to look at tumor detection and classification, to look at fractures, to look at pulmonary embolism. So all those tools are available now. For neuroimaging, these are some of the things that I think are exciting. Some of them which are already developed, some of which are in the pipeline, but things like using virtual contrast. So looking at brain imaging, but let's say a patient is allergic to contrast, right? And trying to figure out if we can avoid giving contrast, but still get good quality post-contrast like images using generative imaging. Um, the halfway of that is looking at augmented contrast. So instead of getting full dose contrast, because again, I think there's a lot of concern from patients about repeated contrast administration in case they have like brain tumors and need a lot of follow-up, right? But let's say you give, 20% of the dose. Uh, but can we use AI to augment that? And it seems like there might be some opportunities to do that. And again, I'm sorry, I'm not dwelling on the images a lot just because of time, but more conceptually, I wanted to tell you what was going on over here. And then since this is recorded, you can go back and look at the images as well. Image reconstruction. So can we use AI? Maybe the bottom row over here is the most critical, is to look at for conventional imaging, if you have some artifact that's causing distortion or abnormality in the images, can you use AI? So this is the actual image to generate images that actually get rid of the artifact, which is this set of images over here. And image upscaling. This one is exciting for me because you can, again, I referred to this briefly, but you can use low resolution images and try to upscale it so that your image acquisition is very, very quick. We're actually trying to explore looking at scout images, which is just the initial set of triplanar images in 3 different views, right? Which take about 90 seconds to acquire. Using those scout images, which are just navigation sequences on MRI, can we get full quality MR images from the scout images? And it turns out you probably could. So we're looking at exploring the use of that to do things like brain volumetrics. Hemorrhage detection. So this is a tool, not this specific one, but this is open source, literature. But there are commercial tools that are available that they can look at hemorrhage detection and segmentation. And beyond, yeah, I think this is actually something that Dr. Chilapa mentioned, but in order to, you probably got a sense of this, but if you end up doing one task at a time, then there's way too many things that AI algorithm needs to do, right? Meaning you need several hundred AI algorithms to look through every single thing that an imaging interpretation requires. So am I going to purchase separate software for hemorrhage detection and tumor detection and, you know, uh, edema, hydrocephalus, brainstem herniation, that kind of stuff? That is impractical. So there are some algorithms that actually combine a bunch of different things and quantify, for example, the likelihood of having a critical finding. For example, are there different types of hemorrhages? Is there midline shift? Is there fracture? Et cetera, right? So those may be helpful in the future instead of focusing on single domain tools. And we'll go into like more broader AI potential tools later on. One tool that people have been using, aneurysm detection, this could be very helpful. And, there's some articles showing that there's, well, I skipped through that very quickly, but saying that aneurysm detection tools are helpful in detecting aneurysms. But concurrently, there's another study, for example, that says that there's a very high false positive rate, meaning that they're not quite sure if an AI algorithm for detecting aneurysm is actually helping or not, because now the radiologist needs to look at it in more detail. And there's a much more recent article that I didn't put in here, but it has to do with a pretty well-known vendor that has an aneurysm detection tool. And it turns out when they did a large-scale study to look at the effectiveness compared to radiologists, neuroradiologists specifically, they did not find a benefit. So with all these AI tools, what we need to do is to figure out are they actually helping the physician? And in my case, radiologist and neuroradiologist, right? Because you cannot make that assumption as a baseline. Case in point is this aneurysm detection tool where um, we tested a commercial detection tool to figure out if they could detect an aneurysm that was actually missed by a radiologist. And it was found, but it also found five other potential aneurysms. Now, if I have to look at five or six times the data to detect something that, in this case, there was a reason why the interpreter missed it, and it was not somebody from Hopkins. I don't know that we would end up missing this, but if we had to look at like five times carefully to find all these other things and then review each one of them to make sure they're not an aneurysm, then it could be a problem. And there are some articles supporting this issue of radiologists' workflow becoming worse because of utilization of AI. This one is for prostate imaging, and then they basically said that it didn't really help with AI detection, improving workflow. This one was about burnout. And there's some studies showing that for some radiologists, when they use AI, then it actually increased burnout because the workload it worsened, right? And so, just briefly, just because of time, I can't go through each one of these in detail, but there's a lot of articles now coming out questioning the use of AI in improving workflow of radiologists. And just quick summaries of this is like inaccurate predictions, which adversely affect performance of radiologists. So now you might trust the AI too much and then interpret it incorrectly, right? So I think this might have been a meta-analysis. Reading times were shortened when, or maybe the other one was meta-analysis, but sometimes reading times are shortened, which is good. But if there were extra abnormalities that AI could detect, then it could lengthen reading times, which is a problem. Um, some other things here showing radiologists reading mammograms are prone to automation bias when being supported by AI-based system, et cetera. Here's again a review article, maybe a meta-analysis, showing that AI studies actually did not help after implementation, right? So here are really the questions beyond just assuming AI is good. But as you implement these AI tools, number one, who's responsible for errors when AI is utilized? And these are things that we think about. I'm on AI governance committees at Hopkins, and whenever we evaluate a tool, we try to figure out some of these questions to determine whether the AI tool may be helpful to use or not. This is a more general question, like if the AI is wrong, then who's really responsible for errors? That's a legislative problem, right? Continuously learning models, I think Dr. Chalapa mentioned this as well, but over the years, AI models can degrade. And so you want to make sure that your AI models are up to date. Bias and generalizability, which is also mentioned, explainability, which was beautifully mentioned by Dr. Chalapa, impact of cognitive bias using AI tools, like I mentioned, as you're just using the tool itself, how is that changing how we interpret imaging? This is a huge question that we haven't really figured out the answer to, but should the data be saved? I mean, my answer is yes, because if you're using it for any kind of interpretation, then it already introduced a cognitive bias that you have to record, right? And then this part, should we make the data available to patients? Should they have to pay for extra information? Because some places are actually doing this. If you want to use AI interpretation, then they're making patients pay for that. And that seems like a problem in terms of accessibility. And then just generally cost and environmental impact of utilizing all these AI tools, which I think everybody knows takes a lot of data centers. So for us, what would really help, tools that are actually helpful in clinical practice. I'll skip over the model card because that's more of a governance thing, but explainability, integration into workflow, and then using, I won't talk about platform models, but generalist medical imaging model. Again, going beyond single-use AI models, but things that people are now calling foundation models, right? Using tons of data to generalize what an AI model can offer. And without going into too much detail, and by the way, ChatGPT is a foundation model for language, right? So is there an equivalent for imaging that we could do? And this article that came out very recently has been going around social media as a popular model now, article now. But using large data. In this case, it wasn't even that large, but they used 220,000 MR images of the brain and then created a foundation model that can detect all of these different things. So you don't have to now create one model separately for all of these different entities, right? This still doesn't encompass everything that we need to know for imaging. So we're going to have much more generalized models using probably like millions of data, but that costs a lot of money and a lot of time. So, in summary, AI tools are rapidly being developed for imaging. I think eventually we would need foundation models, not standalone products. We need to have integration properly with our PAC system to make sure that they're improving our workflow. And each tool that we're using, we really need to do a better job of studying them to make sure that it's helping, not only the radiologists, I focus on radiologists, but ultimately the patients, right? Like, can we have more time to interpret, or can we actually get better at interpretation, reduce errors so that we can help the patients? Thank you so much, and then happy to, I guess,
Yeah.
have the discussion now.
Thank you so much for both of you. It was such an insightful, and I think our community also learned a lot. There are radiologists on the audience, so let's first open up for questions. So anybody has any questions who would like to raise hand or put into the chat, and then we'll go into Q&A. Let's see if Dr. York, I see your hand is up.
Thank you very much. This was an excellent presentation. The pace of enhancement and progress in AI certainly is really exponential, and it's hard for all of us to keep up, and this is very helpful. It's interesting, just a comment, Jensen Huang of NVIDIA remarked that there's a lot of concern that AI could replace or diminish the need for radiologists. Has actually increased it, and there's more imaging being done, and so we have an increase, just like you discussed, of application. But the one question is, there's been some discussion that certain applications and uses of AI in medicine should be considered a medical device and need to get FDA approval or certain very rigorous. It's very interesting too, looking at studies with AI in radiology. In some cases it enhances, in other cases it's not. It's interesting. Burnout, the last thing we want is burnout. But anyway, just for the question out there about the consideration that something would need medical device approval. Thank you.
Yeah. So thank you so much for the question. So it is considered a device, and the problem, though, is that I think people are learning now that using the classification as a device is probably harmful for using AI long term as a clinical tool, because one of the problems is something that I referred to is that drift, and AI tools needing to keep up with slow changes in, in my case, imaging, right? Or whatever it's learning. And for a device, essentially, every time you make a change, you need to go back to the FDA and then say, okay, now I need to make this change. It seems extremely impractical for AI tools to be doing that like each year or every other year, going back to the FDA and say, okay, this is what we changed. And then, now we need to redo our algorithm and our application. But for our purposes, actually, all these things are considered devices. When I'm doing studies on AI tools, then the IRB and data trust, it is classified as a device. It's just, I guess, a new kind of device right now. And then the FDA needs to maybe think hard about, classifying it as a device with an asterisk or nomenclature that would help advance usage of AI tools without compromising it.
Thank you very much. Just to follow up on that, what do you think would happen in terms of reporting adverse events or error in these tools, right? Ultimately, that's hospitals are getting compared each other based on the reporting and everything. Do you know if currently do have a way to report those mistakes or errors?
Yeah, I don't think there's any official guidance from the government or any regulatory body that I know of, but that is a extremely good question because some of the AI tools that have been implemented, right? Like the question is, what do you do if you disagree with the AI tool, right? And then you put an interpretation that's different than what AI said. And then it turns out one or the other was correct and the other one was wrong, and then it led to an adverse event. The easier solution is that AI was wrong, and then the physician was correct. And let's go just beyond radiology, right? In that case, you know, the adverse event, I guess, it was not so much of an issue because the physician at least interpreted correctly. But if the physician is incorrect, the radiologist, let's say the algorithm said, "Hey, there's tumor," and then the radiologist says, "No, I don't think there's a tumor," and then so that's how it's reported. And actually, later on, it turned out to be a tumor. That I don't know. I don't know. I feel like that's gonna end up in a lawsuit. As a matter of fact, lawsuits are already happening. Right. I think you may have seen some posts on social media about AI tools that would help. I think surgical navigation or something. I can't remember what it was, but they were adverse events associated with the usage of AI tools in surgical navigation that caused error in the navigation itself. I'm sorry. Oh, sorry. Yeah. So there are folks in Texas that are now, I think there's lawsuits that are going to start soon because of that. So yeah, I think long story short, yes, I think we need some kind of guidance for reporting um, adverse events and incongruity with, and some kind of follow-up, right, for those kinds of uh, interpretations that are different from what AI is suggesting.
Yeah, so I was at a meeting, I think Joint Commission, somebody spoke, said, yes, the AI reported at pneumothorax, and then everyone was going to put a chest tube, and then radiologist corrected, and that was averted. So those kind of thing, I think that doesn't come to surface, right? Anyway, Dr. Ma, over to you.
Oh yeah, hi. It's Lorelei. I don't have a camera on this computer, but I just wanted to mention that, I do prostate, and we're starting to do prostate MRI AI, and it's just the same things that you said. It was amazing that you said those things, like they have this heat map that is supposed to show you the lesions, but unfortunately it shows you a bunch of artifacts. Like, because a lot of diffusion weighted images in the prostate, when you have the bladder and the bowel, some motion, you
Hmm.
get these spurious abnormalities. And then if you are marking anything where there are positive findings, it saves that whole map. It's part of the data set of the patient's PACS. And
Hmm.
they may say, well, you showed these two, but why didn't you mark this giant purple spot?
Hmm.
And I have to say, well, this giant purple spot is an artifact, but do I have to explain that or something, or
Right.
do I not explain it? Do I just ignore it? There's no real way for me to deal with that. And it'd be nice to have a way to deal with it where you could check something saying that you feel something's an artifact, so that you can move on. But at the same time, as you said, again, it could come back in a court of law where they show it on a big screen in front of a 12-person jury. You know what I mean? Like, Dr. Ma, did you not think that, this tool showed you this? And I
Right.
find it very frustrating. And I actually think, while the data goes across into the report better and faster, though, so it makes the reporting faster, I struggle with, what do I call and what do I not call? So
Yeah.
I think those are the things that can be very difficult if you don't have data sets that are really very um, homogeneous and reproducible.
Absolutely. Yeah, yeah. That's a super good point. And then, the way I look at it is that number one, I think numbers wise, right? When you see all these papers, everybody seems to be happy with like, 92%, 95% accuracy. But that's not very good for in my opinion, because that's like one, in 100-ish cases or two in 100 cases, even five in 100 cases where the interpretation could be wrong, which is not, I think, standard for radiologists. But the way I look at it is like these tools, the equivalent to me is like looking at, non-AI post-processing. For example, again, neural world, but CT perfusion, right? Sometimes when we're doing this for strokes, you will see perfusion maps that show artifact. Now, I have to be confident and comfortable that I can call it an artifact, but I would have to put that in the report saying that there is this thing that's showing up on the CT perfusion that's saying it's a stroke, but I don't agree with it, and I think it's an artifact. I think we're gonna have to do that.
There are methods in at least computer vision side, wherever we see artifacts, and we try to develop another AI to figure out what the artifact is. But artifacts are not predictable. They're a little weird. They're quirky and they're stochastic. So it's always a challenge. This is the hallucination aspect of what AI does. Especially when we are using diffusion models these days, artifacts galore. So we have a challenge. Yep. One thing I always say, if you depend on data, you may also die of data because data is not clean. Data is not pure. Physics is pure. Biology is pure to a relatively extent, but data is impure. They're collected by sensors, and inference purely based on data is a problem. That's why domain is needed. I mean, a physician has to kind of mark artifacts repeatedly, and then we have to train, hey, this is artifact, ignore it, and then it gets better. But again, you should never just go by what AI does. A physician has to look at it, and then only a next stage has to come.
Thank you so much. I'll go to Dr. Fegali, and then I'll come to Dr. York. Dr. Fegali, James.
Yes. Thank you. Thank you both, Dr. Chalapa, Dr. Sayer. That was a very informative talk. I'm currently on my research here. I'm one of the residents of neurosurgery in the hospital, and taken this year to kind of learn about AI at the Homewood campus and take some courses and actually working with data and trying to develop deep learning algorithms, whether it's CNNs or vision transformers and whatnot, and using MRI data. And the thing I noticed working with smaller data sets, let's say 400 MRI scans, 3D MRIs nonetheless, that these algorithms are so good at finding shortcuts. And there's one famous study that I read about that kind of exemplified that, where they were trying to see if a CT scan can diagnose COVID.
Okay.
And then it had like almost excellent performance, and turns out all it was doing was figuring out what scanner was being used, because all the That's categorically what happens to me whenever I'm trying to develop an algorithm, whether I'm like, I have a project where I'm trying to get an algorithm that could tell you from the MRI whether an NPH patient is going to respond to a shunt, let's say. And I know it's supposed to look at the ventricles and subarachnoid spaces and things like that. And then I develop my explainability model, and it's looking at the background or edges of the MRI and the background. And I was just wondering, in your experience, what are some of the tools I can mitigate those shortcuts when I'm trying to develop the model, especially when I'm just using data from one center and things like that, and improve generalizability?
The example I showed, where for the chest X-ray, we were looking at whether age or body mass or sex or gender will impact. Those are the things that we can look at. For example, in your case, we probably will pick up the scanner is very dominant. There is a method known as mutual information neural estimation that will tell you how much of a particular attribute is represented in your features. So if we apply that rule to your data, it will pick up as the scanner is the dominant one, and then it might pick up something. So there is actually rank ordering. We have seen it repeatedly for many applications, face recognition, now chest X-ray problem, body, itself, right? BMI has a big role in determining somebody's gait, well, which is natural, but if you are identifying somebody just purely by BMI, you may make mistake because there may be somebody else with the same BMI. So we have a way of finding, but you should know what are the covariates that will influence. Like in this case, you say scanner. That makes a lot of sense. Long time ago, I worked on a sensor adaptation problem, and I saw something similar to that. So yes, we have a method. That's why once you develop AI, you have to vet it, you have to continuously push it and punch it and kick it and evaluate it. And continuously, that's the challenge, right? It gives you something, it also takes something away.
Yeah, and
Thank you.
in addition to that, I don't know if this is gonna work or not, and then maybe you've already tried this, but like if you feed too much information to the algorithm, then it's going to try to figure out things from all of that information, right?
Mhm.
So what you could try to do is to focus on the area that you're interested. Like the analogy here is like, let's say that it was standard to get a whole body MRI. And then, but now you're saying, okay, we'll put the 3D MRI into the AI algorithm, and I'm going to say, I'm going to ask it to create, a model where it can distinguish between shunt responders versus non-responders in MPH, right? You already know intuitively that everything below the head is probably unnecessary for this.
Yep.
So for the imaging too, if you could try to narrow, especially if you have lower amount of data, right? Then try to narrow what things you think might be relevant features to begin with, and then put that in the AI model, then it might at least get rid of all the other things that, it's circuitously trying to use.
Yeah, that makes a lot of sense. That's what I've tried to do. I've done skull stripping, and there's nothing else in the MRI but the brain tissue itself and the ventricles.
Then,
And I've tried to pick regions of interest, like to narrow it down to the ventricles themselves and the periventricular brain tissue, and it still kind of sometimes picks up on the cropping or the padding that's done in the pre-processing, and it's just so painful. But yeah, it's not as easy as as I thought it would be, and it's just a very hard task to train these models, especially when you don't have a large data set.
Thank you for that question. So it's 7:34, so I think we have two physicians raise their hands, so we'll finish that and then we'll end after that. So Dr. York, hopefully your question is short, and then we'll go to after that, Dr. Taylor.
Yeah, thank you very much. And sitting there thinking about it, reading about a lot of these things, it's clear that what the AI is serving as an agent, sort of like if you're the radiologist, it's sort of like having an intern there. And so they may be right, they may not be right at all. I think the most important thing is that there's a lot of vendors out there, there's a lot of hype, a lot of hand waving, but medicine is a high risk environment. I think it's incumbent upon the vendors to have a method of feedback so that we can very easily, with radiology, feedback this and this and this error was incorrect. What this and this was incorrect. This image and XXX and this, or like I use ambient microphone technology, DAX Copilot. And I'd love to be able to send quick messages back to Microsoft about how this and that was wrong and needs to be improved. So I think it's just a comment out there about we need to be insisting that the vendors are putting this type. So if you have software, let's say you download something that's on your Mac, and it doesn't work, it crashes, then something comes up where you can send a message to Apple about the crash and why it happened. It's that kind of idea, but at a much higher level. Anyway, thank you again. That's my only comment.
Thank you, Dr. York. Dr. Taylor?
Thank you. Enjoyed the presentation. One comment, there's an interesting article in the JAMA, January 20th, about guidance on responsible use of AI. And my guess is that most physicians aren't going to do all the things that were mentioned in this JAMA article. But my question is, how are you dealing with the issue of it takes a lot of pictures, a lot of images for AI to learn and input to tell it what the reading ought to be from this or that picture. And that means that a lot of patients have to be participating in allowing their images to be used. Are patients giving permission for this, or are they just assuming that de-identified patient data is okay?
That is an amazing, amazing question that has been discussed across the country, and different places seem to have different approaches for it. But yeah, maybe I alluded to it about, patients' contribution to designing these models, right? And currently, the thinking is that, as you noted, it would be not feasible to get consent for each patient. So it's going to be more like de-identified retrospective analysis of the data that's already obtained.
There is a technique known as federated learning. So, they may not share data, but if they can build models, these models can be combined together to come with, so indirectly mining Again, still you have to do the de-identification, but you can have a lot more data. So federated learning is one way to address this issue, taking data from, MD Anderson and Boston hospitals and here, there, Hopkins, Maryland, etc. Each one they have to build models and then we have to aggregate them. It's a very elementary technique still. Averaging of these nonlinear models is the only way people are doing it. That's not good enough. And we have to still take care of the fact that different data has different distributions. We have to account for that. So it's pretty complicated. But yes, without data, there is not a whole thing. Although in some applications, I'm not proposing this for medicine. We know how to generate synthetic data. That kind of we try to use that. Somebody said by 2030 we would have used all the real data. So the only way we can do anything is to go to synthetic data. I don't know about that, but that is one possibility. People are even synthesizing MRI and this and that. And, we have to look into the impact of that in the decision-making process. So that's one way out. Yeah.
I know Dr. Wolf raised her hand, so that might be the last question. Dr. Wolf.
Yes, hi. Thank you both very, very much. It was a very informative lecture. And from MedKai's perspective, I think I can see the political ramifications that may be coming with this, especially if it's pushed from the insurance companies on you, as you said, to maybe lower the number of radiologists. But I completely understand and agree that it's workflow related. My main question is, especially if you're combining databases and you're joining information from all different kinds of places, and the AI may take the Occam's razor or the simplest path. How do you find the piece that it's hooked onto that it is using to this decision making, like when it was which scanner that was used? How do you get to the bottom of that and figure out what it's doing?
Well, there are methods to probe into the embeddings you build from data into what other things it codes. I'll give you a very simple example. Diabetic retinopathy AI is one of the first AIs that FDA approved. Everybody was surprised that in addition to retinopathy issue, it also figured out the gender, which it was not supposed to do. So you have to probe, what other thing it has, like the scanner information that came as a surprise. So we have some methods, but can I tell you, we all talk about AI, but if you really take all the shine and everything off, it's a nonlinear hierarchical regression model. That's all what we are doing with AI. 101 layers of convolutional neural networks. It just tries to approximate the mapping from data to labels, cancer, no cancer, right? So it's actually not AI in the classical sense of AI, it's a nonlinear hierarchical regression model. So we have some techniques to handle that, but we cannot quite handle the 101 layer of nonlinearity. So you have to systematically probe whether the features represent gender or BMI or age or ethnicity or race. A classic example, face recognition didn't work well for dark-skinned people. So that created a shock in 2018. So you have to continuously probe and evaluate because you know what? Data is not clean. So that's the problem.
So I have a last question for both of you. So for first, Dr. Chellappa, you spoke about this bias, data shift, domain shift, drift, all this. How do you see that as a medical community partnering with AI developers to mitigate those challenges in real practice? Because I feel like right now, clinicians' involvement is less. It's driven by industry.
Yeah. No, I have 8 collaborations with School of Medicine groups, various groups, endocrinology, geriatrics, brain, OCT-based brain cancer, eye care, rehab, and so on. And we even wrote a paper in terms of a finger, somebody's finger is cut, whether you have to take them to emergency or not, and so on. We have a paper in plastic and reconstructive surgery and so on. So in every one of them, I have doctors, 2 or 3 doctors, and we sit together, we look at the data, we develop the method. We even have a method for remote estimation of heart rate from video. Again, I have doctors involved. So as I said, writing a paper just on benchmark data, medicine data, is of no use. You have to involve somebody like Dr. Sayer from day one, and so he can tell us what's wrong and so forth, and he understands the machine learning algorithms. So that is how it has to be. It has to be a AI person plus a clinical person. Otherwise, it has much value. So that's how it has to be. It
Yeah.
is challenging sometimes, but for example, even among data, some data is very hard to share. The NF data, for example, right? It's patients are without clothes and so forth because of the skin lesion, extremely sensitive data. So we have to go to that space if you want to work on it, right? And Tesla, but I care about an AI plus radiologist working because that will make our health better.
Yeah, we and Midka, I really value that. And I think we have a lot of doctors, experts who could be part of that. It's just a matter of navigating this. So, Dr. Sair, your question. So I know you've been doing this for a while. What do you think is going to happen in radiology 5 years down the road? As like, if you have a crystal ball, what do you think is being like? What do you see will advance, and what type of things you would see in radiology?
I think so. In the next 5 years, probably not much is going to happen, is my guess. But what I'm looking forward to, what maybe could happen in 5 years, I don't know. You never know, like when there's like transformational technology, right, that can shift domains, which is initially what happened with what Dr. Salapa mentioned with convolutional neural networks. But now with the push towards foundation models, I think that's where the biggest focus is, at least in imaging, but I think healthcare in general. So multimodal foundation models, meaning you put a language model, you put a vision model all together, and then try to develop a model that can be as general as possible. That's going to take insane amount of data, but maybe there'll be like a technological transformation that reduces the need for that data. But once you have these models, what's to me exciting is that um, you can then develop your own submodels, right? So let's say you have a foundation model for just say MRI interpretation. You can then teach it very quickly, okay, even if it doesn't know how to distinguish between like a microadenoma and a macroadenoma at that point, with that kind of a model, you can teach it to do that very quickly. And what's interesting about this is what I'm learning from the regulatory part of it is that if you develop your own model and use it in-house, then you don't need to go through all of the governmental like clearance that typically you would have to do if you were going to use a commercial product. So that means that if we purchase one foundation model, we can generate unlimited number of downstream models from that we are interested in specifically, right? So to me, that seems like a uh, interesting and exciting possibility in the near future.
Well, finally, thank you so much for your time and being here with us. And Medka, I really deeply value like thought leaders like you who really help us to navigate these exciting but complex and challenging changes in healthcare. Thank you so much. And for our audience, thank you so much for participating. We have a lot of past Medkai chairs here and current president is here. So thank you so much for everyone and for the staff.
Thank you very much for having us.
Yeah.
Mhm.
For the
Excellent discussion. Thank you very much.